Hey, good morning, everyone. So I'm going to talk about a topic that we don't think about often. And I hope that at the end of this presentation, I can share some pearls about how to be aware of our own cognitive biases, as well as remaining humble with lifelong learning. So just a few financial disclosures, and I am the editor of a textbook on neuroprognostication, which is going to be in press soon. But here are my real disclosures. This is how my brain works. And throughout this presentation, it's important for me to share this with you so you can understand where I'm coming from. So my brain is always thinking time is brain, and we've got to do the right thing. And then when we're presented with new data, we've got to think again. And for me, resuscitation and recovery are part of the same continuum. And it's very important to leverage team-based dynamics to provide the best possible patient and family-centered care. And you've got to provide this care in line with someone's goals, values, and wishes every step of the way. Why I love neurocritical care. I've been doing this for about 10 years now. And there are various reasons why I really love doing what I'm doing. But the most important ones are teamwork. It brings out the best in everyone. It's uniting us in this mission to help people, particularly at a time when they're feeling their most vulnerable. It behooves us to provide care in line with someone's goals, values, wishes, in light of new knowledge, new skills, new technologies every single day. And this lifelong learning model, innovation, really helps us find purpose and meaning. So across the board, you see a lot of different types of neuroemergencies. So we're in a very high stakes environment together as a team, whether it's neurology, neurocritical care, neurosurgery. And for all of us, time is brain. And irrespective of the decisions we make in this high stakes environment, we know lives are going to change, not just our patients' lives, not just their families, but also us. So now I want you to take a pause and think about that last patient you missed a life-threatening diagnosis on. Then think about the last patient you misdiagnosed. Take a moment to think about the last patient you lost, awaiting some definitive intervention. Think about that last patient you withdrew life-sustaining treatments on. And think about that last patient you declared brain dead. We know that diagnosis in neuroemergencies is very hard. Why does this happen? Why are we missing diagnoses? Why are there missed diagnoses? Well, even when we look at the example of stroke, in this study, they looked at ED diagnostic accuracy of stroke. And despite us thinking that stroke is perhaps one of the easiest diagnoses to make, and we know it should be top of mind, why are we still missing diagnosis? I mean, you look across the board, anywhere between 7 to 41% misdiagnosis are happening in the ED. This may happen because of atypical or mild presentations, which may be more difficult to diagnose, but there are massive implications of missing or misdiagnosing these patients. In a systems of care approach, we hope that the system will support us, in making the right diagnosis. So there's regionalization of care that the IOM supports. The National Academy of Medicine says we should be able to provide better care if we do the same thing at the same place at the same time. But care really needs to be patient-centered. And that fragmentation, as we regionalize care, perhaps we can prevent fragmentation and we can prevent variability in care delivery, right? So regionalization should improve our ability to improve clinical diagnosis and to mitigate care variability. Another key concept that I want to share with you before we delve deeper into how we make clinical diagnosis is patient and family-centered care. So what does this mean? This essentially means that care needs to be compassionate, it needs to be respectful, and we've got to think of families as partners, patients and families as partners, collaborators in decision-making. Care needs to be safe, effective, efficient, and equitable. There are common grounds, whether we think about the acute care setting, whether we think about the outpatient setting, whether we're thinking about recovery. So what are these common grounds? Regionalization, the vulnerability that comes to care because of fragmentation, and innovating in this care environment to uphold patient and family-centered care. I've conceptualized empiric phases of care for neuroemergencies in this manner, moving from one phase of care to another. So irrespective of the phase of care that a patient is in, we will need to make different kinds of clinical diagnoses for them and act on them. So how do we make diagnoses in any care setting? So this is from the Institute of Medicine's report on improving diagnosis in healthcare. So a patient experiences a problem. As we move from the left-hand side of this diagram to the right side, experiences a health problem, engages with the health system, you take their H&P, you may send them for some tests. So your information gathering, you come up with a working differential. You think this could be either a tumor, this could be benign, or this could be malignant because they have a prior history of a malignancy, etc. So you're gathering all this information. You have your differential diagnosis. You're integrating this information and then interpreting all of this data. And with all of this data, you're communicating that diagnosis, and that's going to affect your treatment plan. So this seems very simple, very intuitive. We do this every single day, no matter what care setting we're in. But then why do diagnostic errors occur if we're practicing the same thing over and over again? Why is that happening? Well, this is not happening in isolation. It is happening in a system. So you've got, whether it's the organization, the system of care delivery, your team members, the physical environment, the different tasks that need to fall into place for you to make this diagnosis. So the IOM defines a diagnostic error as the failure to establish an accurate and timely explanation for a patient's health problems and communicating this explanation to the patient. So how do we make clinical diagnosis in neurocritical care or neurosurgery? So think about your care setting. And from the perspective of your care setting, the speed, how quickly do you need to make this diagnosis? Are you in the ED? And do you need to activate the OR as a category 1, or do you need to take this patient to the ICU to stabilize them? Irrespective of the setting, you're going to think about how quickly do I need to make this diagnosis. Sometimes you may encounter a patient in your outpatient setting who needs to be referred to the ED because you were not expecting them to have a new onset seizure in your office, or you were not expecting their blood pressure to be systolics in the 50s. They were just not feeling good. But irrespective of that care setting, recognizing how quickly do I need to make this diagnosis? How certain do I need to be in my diagnosis? So how life-threatening is this process? Do I need to parallel process? Keeping that diagnostic window open despite the speed of diagnosis is important because you don't want to prematurely close your diagnostic window and commit commit yourself to this error of commitment to a particular diagnosis too early in the process. How do we institute empiric treatment? So it's not like you wait for a firm diagnosis. Sometimes we may start treating a patient. Think of that brain tumor patient who you think had a witnessed clinical seizure, and they're not really waking up. They've been referred to the ED. As is well known, sometimes there are delays in getting EEG connected or getting a bed in the ICU. It's not like you're going to wait to begin treatment. You're going to start treating them for that new onset seizure. You're going to send them for imaging. You're going to try to figure out why is this happening. So you're going to parallel process. And then these definitive treatments, how invasive do they need to be? So how certain do we need to be in our diagnosis based upon how invasive or high risk these definitive treatments are? But it's also important that once we commit ourselves down a particular pathway as more data emerges, in a multidisciplinary team fashion, that we are changing our diagnosis in light of that new data. Or the patient's condition may change and you need to revisit your diagnosis. This is how the IOM conceptualizes clinical decision-making. And what does this look like? So essentially, collecting data, analyzing relevant information, making a judgment, and then based on that judgment, doing some decision-making and then decision acting. But after decision acting, our job doesn't stop there. We should evaluate the outcome of that decision, both for that particular patient as well as to become better the next time around. So let me give you a very common example in an ICU setting, right? So here's a patient who is a Hunt and Hess 4, modified Fisher 4. They've had their aneurysm coiled already. It's day 14. They've already had some increasing TCD velocities, and you've had them on milrinone, and their exam is good. Their cardinal sign is that they're following commands. So on day 14, they start having this fluctuation in their exam while they're on milrinone. So what is the first diagnosis that's going to come to your mind? So you're probably thinking, okay, maybe this patient has vasospasm. Maybe I need to change their blood pressure target, or maybe I'm going to try to up titrate that milrinone and see if the exam gets better, give some fluids, etc. So you do that, but the patient's exam doesn't get better. So now your exam is fluctuating. You talk to the endovascular team, say, we noticed this in the ICU setting. We let the on-call neurosurgery resident know. They come to the bedside. We notify the INR team. So everybody's thinking, okay, maybe this is vasospasm. We need to go down to angio. As we're waiting to get further information, whether it's a CT angiogram, whether it's TCD, whether it's both, we're still going to start some empiric treatments. So we start raising this patient's blood pressure goal, say we'll change the blood pressure goal now to greater than 180, and we re-examine the patient. Well, there's still no change. We send the patient down for a CT angiogram, and we do see some spasm on that CT angiogram. And we know from yesterday's TCD report, well, the patient's TCD velocities were increasing. For all practical purposes, this is vasospasm. You send the patient down to angio, but there is no spasm on the angio. So then you take a pause and ask yourself, then what am I dealing with? Then what is this? So for the residents on the call, I can't see any residents as panelists, but Peter, is it possible to ask people questions?
Yeah. You can.
I can. Okay. All right. So residents, let me see who.
Yeah, we can elevate.
Got it. Awesome. Thank you so much. So while we wait for some of the residents to come up as panelists, I want you to think, and you can type in chat as well. What are you thinking? What are your possible differentials for this patient with a Hunt and S4, modified Fisher-4, ACOM aneurysm, coiled, and they've got this exam fluctuation, they're not following commands. So what are your differentials? And feel free to type in chat. I'm just monitoring chat right now. Okay, so I see Halima. Oh, what are your differentials? I see you as the first resident up here, so.
I would think of possibly seizures.
Okay.
And would want to put the patient on EEG.
And what additional data do you want right now at this point in time as you're developing some differentials? Do you want me to give you any more information, or you have enough?
So I see that we have CTA and TCDs.
Mm-hmm.
And we've already tried pressors, as well as we've done a definitive test, which is angiogram. So our top differential at this point in time would be spasm, but the patient does not have spasm. So we've already ruled that out.
Mm-hmm.
So other things that I want to rule out is metabolic causes, and then seizures.
Okay, so then I'll add some more information. I'll give you more data. So this patient is febrile, and they just failed a trial of extubation. So we re-intubated them. And they've got some foul-smelling copious secretions. So now what are you thinking?
Then they might have an aspiration pneumonia, and the sepsis or the fact that they have a pneumonia would be contributing to the fluctuating exam.
Absolutely. And now I'll give you one more piece of information. So empirically, this patient got started on vanc and cefepime. Now what are you thinking? Does it change your differentials? Does it keep it the same?
And you can still have, depending on when we started, they can have a pneumonia from an organism which is resistant to the vancomycin. And then they also potentially have cefepime toxicity.
Absolutely, very good. So they could also have cefepime toxicity. So something that our treatment was meant to do may have this, this side effect or this adverse effect. And we need to keep the effects of our treatments in our differentials as we disprove or prove a hypothesis, right? And if I told you that this patient was draining more than 400 cc's of CSF every single day, right up till the time they go for their angiogram, and in that 24-hour period, they drained only 247 cc's. Now, do you add anything more to your differential?
So they could have hydro and built up of fluid from not enough drainage. That could also be contributing to this.
Absolutely right. So what you've essentially done is you've taken data You've expanded on the hypothesis and you're going to prove or disprove. And while you're waiting for more data, you're going to start acting on multiple things, right? So for this particular patient, as we're thinking about the need for an accurate, timely diagnosis, in this framework, the work system, who are our team members, what tasks need to be assigned to them, what technologies and tools do we need, how do we organize ourselves, how do we begin empiric treatments, narrow down our differentials, and take away certain things which we think may be causing harm. For example, cefepime-induced encephalopathy in a patient who is already septic, thinking about changing their antibiotics to an appropriate antibiotic that may cover an organism. I didn't tell you whether we had an organism or not, and you could have told me, oh, we should narrow it down because now you have, methicillin-sensitive Staph aureus in sputum. Why do you need cefepime, right? So those diagnostic errors, those are all together going to impact patient outcomes as well as system outcomes. And in a learning health system, taking all that learning, feeding it forward to our diagnostic process so that we become better, we become more efficient, we become safer every single time. So what did we do for this patient? So as Halima said, we did all of those things that Halima said. We re-examined the patient. We lowered we did on that CT head, we found, okay, yes, there is worsening hydrocephalus. So let's lower that EVD. Seizures was a top differential, and we did stop that cefepime. We happened to get our methicillin-sensitive Staph aureus back in sputum later in the afternoon, but changing our treatment pathway, loading with anti-seizure medications, weaning those pressors, because now we don't need that milrinone and that levofed for a blood pressure of more than 180. So we don't need certain things, but we need others. So despite all of this, why are diagnostic errors occurring? And then who is carrying the burden of diagnostic errors? So this report from the IOM, I'm sure everybody on the call has heard of this report in one way or the other, you may have read this report to err is human. It is very natural for us to make mistakes. And about almost 100,000 preventable deaths occur in the United States because of such preventable error. And then who's suffering from these diagnostic errors? These diagnostic errors, these medical errors are costly, and they're estimated to cost a lot of money. And when we consider adjusting for quality of life, so quality adjusted life years, the cost is even more. So now let's dive a little bit deeper. This is a complex looking slide because this is a complex problem. Why do diagnostic errors occur? So there's a body of literature which I wasn't looking at very keenly until I got interested in understanding how we're making these decisions. So Peter Cross-Carey is a good person to start reading a few papers from. In this review paper, they talk about 6 clusters. And there are about 60 factors that can potentially contribute to us making a diagnostic error. So A, essentially, are the demographics of the decision maker. So for how long have you been doing this? What is your experience? How much do you know? What is your intellect? B is your cognitive characteristics as a decision maker. What is your personality? Do you lean on critical thinking? Do you have the ability to reflect? Do you reflect and cope with your diagnostic errors? Do you adapt? C are those factors, those homeostatic factors that happen to us we're human, whether it's hunger, whether it's sleep, whether it's the environment, whether it's fatigue, it affects how we make decisions. D are those ergonomic characteristics, the decision maker's environment. What is our environment like? When you're making certain decisions in the OR and say the instruments that you need are not here and you pause, or you're down in the ED and the ED is super crowded and you're getting 5 consults and the ICU is also calling you, that environment and that cognitive load and how you're processing can potentiate some of these diagnostic errors. What about the disease itself? And what about the patient themselves? So E is that cluster where the manifestation of the disease, how familiar are you with some of those signs and symptoms? What are the comorbidities? How do you anticipate this disease process is going to progress? And then F cluster refers to the patient, the caregivers, the friends, the family, the psychosocial context, etc. Right? So if you think about what we are doing every single day for every single patient when we're making these diagnoses, it is super complex, and no wonder we are prone to making some of these diagnostic errors. Now, several of you on the call may be familiar with Dan Kahneman's book, Nobel Prize winner, who talks about these two systems of thinking, right? Type 1 and type 2. Type 1 is fast. You make these snap decisions based on either experience or deduction. You've got some data. You're constantly scanning the environment to gather more data. It's fast. It's very efficient, but it's error prone. And it's really based on impulses, on intuition. And system 2 is slow thinking. Having the ability to take that one step back, you need very specific information. For specific problems, you're going to lean on system 2. It's slower, it takes effort, it takes time, and you've got to exercise self-control. It's slow, but very reliable. So when are we prone to making more diagnostic errors? So I showed you all those different factors. Now think about your day-to-day, your individual patient, your overall patient load, your environment, the ER, the ICU, OR, floor, your resources. Do you have the time? Do you have the bandwidth? And it's not just your clinical responsibilities. You've got all these other responsibilities as well. And then skill level, knowledge, and then at a personal level, those homeostatic factors. So type 1 thinking that we lean on very often, that uses this deductive reasoning, pattern recognition, it really helps us. And it's been studied that type 1 thinking helps in residency, for example, because we have all these time constraints and there's all this increasing workload, there's sleep deprivation, so we end up leaning more on type 1. And as diagnostic errors are occurring, their impact, a lot of malpractice claims, more than 90% of malpractice claims are going to be because of clinical decision-making or judgment failures. And about 75% of these errors that we make are cognitive in origin. They're a judgment problem. And I'm sure you've all heard of this review paper that was published in NEJM that looked at diagnostic failure in the emergency room. Uncommon presentations of common problems, esoteric diagnosis, or very quickly narrowing your diagnostic window and making this error of commitment that you're just going to go down this one pathway and ignore all the other pieces of data that are telling you otherwise. This premature closure, this error of unpacking. And then, of course, while we may think that a lot of errors happen because of lack of clinical knowledge or skills, you'll be surprised that this is a minority of, they have a very small contribution to diagnostic errors. So when you think about that signal to noise ratio and this manifest continuum, how do diseases reveal themselves to us? So that high signal to noise ratio, when you see the pathognomonic findings for a particular disease process, oh, this is absolutely, when you look at a particular rash, or you look at, when you look at CT of the spine and you see a particular type of displacement or fracture, etc., it's very obvious that, yes, this is the problem. However, you've got to tie that into rest of your data. Is it making sense with the patient's clinical presentation, or am I dealing with a red herring? Or is this an incidentalloma? I just happened to find it because I scanned for it, right? And as we move those clinical signs and symptoms, this continuum moves towards a lower signal to noise ratio as we move towards rarer conditions or atypical presentations. So we have to be even more careful. Every single year, there is at least a handful of patients with basilar occlusion who get missed. We're thinking stroke. We're a comprehensive stroke center. For example, at Mount Sinai Hospital, we take care of so many stroke patients every single year because there are a lot of differences in how these patients will present, right? Now, what about in an ICU setting? It's a data-rich environment. It's an environment that leans on a collaborative approach. We're missing about 1 in 4 diagnoses. In an autopsy-based study that looked at diagnoses that were missed that contributed to death in an ICU setting, about 1 in 4 cases were misdiagnosed. And why is this happening? Maybe in part because we're dealing with multi-system problems. Maybe in part because we're dealing with complex dynamics between the different systems. But more importantly, when these authors looked at what problems were missed, well, it was the more common diagnoses that were missed, perhaps because our focus is on the more complex problems and we may end up missing common problems. So be aware of cognitive biases. There are lots of different cognitive biases, but these are the 6 most common ones. Availability bias, confirmation bias, anchoring bias, this framing effect. You know how you present, how you pick up the phone and present a case to your attending may lead your attending down a particular pathway. So this framing bias, diagnostic momentum, you gather data, you think, of course, we're seeing what we wanted to see, and we attach diagnostic labels to the patient, and we don't end up revisiting our diagnosis. And this premature closing our diagnosis without looking or completely ignoring all that additional information. So the art and science of medicine, we know that medicine is a science of uncertainty, and it's an art of probability. And evidence-based medicine is relatively new. So when we think about this art and science of medicine, it's very humbling. So why is medicine an art? It's an art because we look at sympathy, compassion, empathy, justice, non-judgmental attribution, kindness, all of these things that are very hard to quantify scientifically. That's why medicine is an art as much as it is a science, and it's an imperfect science. So recognizing, so this one concept of uncertainty in medicine propels us to explore dilemmas. It's important to recognize cognitive dissonance and embrace this uncertainty. Medical education doesn't teach us what to do with uncertainty. It makes us very uncomfortable. And this has been studied in a survey that looked at how often medical schools and undergraduate programs were incorporating this skill of managing uncertainty. Well, less than 50% do that. So when do we learn about clinical reasoning? Most of the times we think that by experience, by doing more, we're going to learn clinical reasoning. There is no deliberate effort to teach clinical reasoning. So why do we need diagnostic humility? Because we don't learn clinical reasoning enough. We're leaning in a very complex environment, on a very complex way of doing things. You may have heard of the Dunning-Kruger effect, where our confidence and competence are not linear. When we'll be very confident when we know very little, or we may have minimal competence, or we'll feel the smartest perhaps when we're interns, right? Or when in medical school. And the more you learn, the more you realize, the less you know. And being aware of this effect, being aware of our cognitive biases, acknowledging uncertainty. How do we overcome uncertainty? By using type 2 system 2 thinking, by being very critical in our thinking. And for teachers on the call, and all of us are teachers in one way or the other, right? So this 5-step framework for teaching critical thinking: ask stimulating questions, model and teach inductive reasoning, and assess whether our learners have actually learned how to think clinically. So in the next few minutes of the talk, I'll talk about, from diagnostic humility, why we need to remain very humble as we keep getting smarter. Now let's talk about prognostic humility. We cannot be too sure. And we all know on this call, we all know we cannot be too sure. So think about that last patient that you thought would not make it and made it. Think about that last patient who totally surprised you. You thought they were going to make it and they just didn't. Think about that patient who you saw make a good functional recovery, especially when you least expected it. And then when it comes to withdrawing life-sustaining treatments, think about those patients who you thought you should not have withdrawn life-sustaining treatments on, or perhaps you should have earlier. And in these empiric phases of care, as we move from that diagnostic humility towards prognostic humility, we're moving towards guiding patients and families and getting them ready for that new state of normal. So what do we need? What do we need to know? So that primary neurological injury has already occurred. The secondary neurological injuries, whether it's cerebral edema, seizures, ventriculitis, all of this, along with systemic injuries, is all going to contribute to prognosis, what is coming next, and how do we optimize patient-centered outcomes and prepare our patients and families for that new state of normal. There is so much data. We can gather data, we can look at numbers, systemically invasive, non-invasive parameters, both for the body and for the brain. And despite all of this, neuroprognostication is very hard. And we know neuroprognostication is very hard, and we've got one size is not going to fit all. How do we personalize care while we also improve our ability to diagnose and prognosticate at a population level? There is a whole body of literature that talks about withdrawal of life-sustaining therapies in different kinds of severe acute brain injuries. And despite all the uncertainty in prognosis, we know, irrespective of the type of severe acute brain injuries, more than 50% of these decisions to withdraw are being made within 72 hours. As a result, we wonder if there is a good proportion of patients who may have made a recovery in whom we end up withdrawing life-sustaining therapies. So there was a joint professional standard statement, and the Neurocritical Care Society, they recommend that we should wait, we should give time before we withdraw life-sustaining therapies. And then you wonder, is 72 hours really enough? And then on the flip side, there is a cohort of patients in whom you don't need to wait 72 hours. You may see a devastating lobar ICH dissecting into the brainstem. Do you really need to wait 72 hours in those sorts of situations? Now let's take the example of a decompressive hemicranie. And I'm going to ask, I see Brandon on the call. So Brandon, you have a patient in whom, what data do you think you will need to decide whether you need to put decompressive hemicranie as a treatment option on the table or not? Say this patient has a left MCA territory stroke and they underwent thrombectomy. Now they have an established stroke. What data points are you going to take into mind when you are deciding, are we going to put decompressive hemicranie on the table or not? So Brandon?
So we need to consider MRS functional status.
Okay.
Those are the main two.
So for you, the most important thing is going to be that pre-morbid functional status. Does age matter, Frank? Any other factors that you would want to know before you put this option on the table?
Age definitely matters, and which side, dominant hemisphere, non-dominant hemisphere, would also be important. And then if you have an MR to show the extent of the stroke burden, I think that would also be pretty helpful.
Okay. And anybody else wants to add any other factors that they would want to know? The problem with making some of these decisions, right, on day 0, when we huddle together at the bedside, the neuro ICU team, neurosurgery, and we're trying to figure out, okay, should we put this option on the table or not? We need to have a consensus amongst ourselves, right? And we cannot have lengthy theoretical discussions because we know time is brain, and a patient can progress to herniation right under our nose while we're trying to have a lengthy discussion about quality of life. So how do we make these decisions? Appropriate patient selection. It could be guided by evidence. We may have some evidence to support our decisions, or consensus amongst the different team members who are usually involved in making these kinds of decisions. And then, of course, case by case. And it's important to emphasize that this kind of surgery is a life-saving surgery. And you've got to elicit whether survival with disability is okay. Is this in line with the patient's goals, values, wishes or not? And those best case scenarios, worst case scenarios, they're pretty complex for a surrogate to wrap or healthcare proxy to wrap their heads around, particularly when they're dealing with something that is devastating and you're asking them to guide you in providing care in line with a patient's goals, values, wishes when they can't speak for themselves. So the most important message, irrespective of what data points you're going to use to put this option on the table or not, the surgical and the medical teams need to be on the same page before we approach the family. You've got to present a united front. And being aggressive, and this paper in a bioethics journal talks about how to deal with uncertainty. And there's data to support that being aggressive early brings more certainty one way or the other. So how do we prognosticate? We're looking at patient-related factors and disease-related factors, treatment-related stuff, goals, values, wishes. We'll try to gather more data, imaging, neurophysiology, scoring systems, etc. We take all of this data together when we try to prognosticate for our patients. And despite that, it is very hard. And despite that, we are wrong often. And despite that, patients are going to surprise us. So when we think about the needs, when we guide patients and families, and particularly when we know that surrogates are going to be making decisions or communicating decisions on behalf of the patient, that process of sharing information with patients and families and making them an integral part of that decision-making model is called shared decision-making. And the needs of the patients and families are going to evolve from an acute care setting to a long-term recovery setting. Initially, there's going to be this need for practical information, what tests, information on guiding treatment, appropriate placement, etc. And sensitive information that is harder to be certain about. What is the prognosis? What is going to happen in the long term, code status, etc. All of these needs are going to change over time. So for this particular patient, I heard age would be, you would want to know the age, you would want to know the pre-morbid functional status. Well, there's
Neha, we have just a couple minutes left.
Yeah, there's some data. Thank you so much, Peter. There's some data to suggest that handedness matters, right? And the evolution of care for this patient, and I'll show you how this patient ended up doing. That patient was a 72-year-old with status epilepticus, with hemorrhagic transformation. And based on that patient's goals, values, wishes, that patient got offered decompressive hemicraniecte. This is just an example of subarachnoid hemorrhage and what factors you may take into account as you prognosticate. Lots of different things that may be taken into account. Similarly, for traumatic brain injury, this comes from a paper in the Continuum. We know there are lots of gaps in how we're prognosticating. We don't have external validation of a lot of the models that we end up using. The scores are imperfect. For ICH, the American Heart Association guideline statement specifically highlights that while using that ICH score, we can quantify severity, but it should not be used for decision-making, for guiding prognostication. A general framework for communication is used using that severity score, but should not be the sole factor used for forecasting a poor outcome. They've also got recommendations on shared decision-making. Is reasonable, it's needed. And not withdrawing life-sustaining therapies in the first 24 hours is also reasonable. In rehabilitation and recovery, this multidisciplinary team effort is needed, and multi-domain outcomes at different phases of care, physical, cognitive, mental health. So this guideline statement did a really nice job of highlighting that. So just revisiting this decision-making, when we look at neurological function from brain injury, the point of prognostication may be early, depending upon the need for a life-sustaining process or not, and knowing that that's only going to save someone's life, but what is that anticipated trajectory for recovery is broad. There is this cloud that we can come up with as estimates of what recovery is going to look like. And because these are estimates, we will rely on past patient experience, our own experience learning from those patients, surrogates, as well as population data. So keeping that in mind, these are some of the things that you want to keep in mind as you formulate your prognostication, make a decision, and then translate that decision for the families. A lot of patients do end up making meaningful outcomes despite having prolonged disorders of consciousness. And just be aware of this concept. There are evolving concepts. There's overt consciousness that we can test at the bedside, but there's also hidden consciousness or covert consciousness that you can only measure on functional imaging or EEG. Multi-domain impairments are going to affect all of our patients, and there's unintended consequences of our treatments that patients are going to suffer from. And as they move from one end of the spectrum to another, there are going to be ups and downs, and those ups and downs are going to contribute to recovery. Very few stroke patients end up following up long-term. And in this systematic review that looked at outcome measures, the very few studies address what our patients need, even for stroke patients. So there's need for multimodal rehab because there are multi-domain impairments, and we've got to treat patients as full human beings. For this particular patient, in the interest of time, I'm going to skip over. And I'll wrap up.
We need to move to our next speaker.
I'm going to wrap up with the last slide, which are your take-home points. So give me one moment, Peter. I'm just going to scroll down to the take-home points. So what we went over today was both diagnostic humility, the need to stay humble, the need to be aware of our cognitive biases and blind spots, prevent diagnostic errors by being systematic and deliberately practice this. And the more you practice, the better you're going to get at it. Very important to not fall into this trap of self-fulfilling prophecies and acknowledging uncertainty. And sometimes it just needs time for you to overcome those uncertainties. So thank you. Thank you for the opportunity to think more deeply about this topic and sharing some of those thoughts with you.